Hello everyone, my name is Ronnie Ren. I am an assistant professor in emergency medicine at UMass Medical School Emergency Medicine Residency Program. And I was a former graduate of a Baystate Emergency Medicine Medical Education Fellowship. Today I'm going to be talking about subarachnoid hemorrhage. Subarachnoid hemorrhage is a bleeding into the subarachnoid space, usually caused by a ruptured cerebral aneurysm. It accounts for 3% of all strokes and 6% of all acute severe headaches in the emergency department. There are some misconceptions about subarachnoids, like people with it should appear ill, or that they should have some kind of neurologic deficit, or that it's the initial bleed and the continued bleeding that ultimately kills the patient. In reality, a large number of subarachnoid hemorrhage patients will not look ill at all or have any neurologic deficits. And in fact, most subarachnoid hemorrhages, the initial bleeding stops. What kills patients is the rebleeds, often occurring within the next 48 hours of initial symptom onset. These rebleeds lead to cerebral vasospasms that cause strokes, and subsequent bleeding, cerebral edema, and hydrocephalus raises intracranial pressure, ultimately killing the patient. The only definitive way to treat the subarachnoid hemorrhage is to fix the ruptured aneurysm itself. But that's the neurosurgeon's job. Our job is to detect the subarachnoid hemorrhage between the patient's first bleed and the patient's last. Today, I'm going to talk about the 3 factors that cause physicians to miss a subarachnoid hemorrhage. The first factor is the failure to appreciate the full spectrum of a subarachnoid hemorrhage presentation. And we'll talk about a lot of the clinical features that can help us in risk stratifying these patients. Second is the failure to recognize utility and the limitation of CT imaging. And we'll take a look at what the guidelines have to say about how we should image these patients. And lastly, is the failure to obtain a lumbar puncture and to accurately interpret the lumbar puncture results. And we'll take a look at what the evidence has to say in terms of interpreting a lumbar puncture after a traumatic tap. Let's talk about clinical presentation. The textbook presentation for subarachnoid hemorrhage calls for thunderclap headache. But what does that mean? Well, in literature, thunderclap headache is described as a headache that reaches maximal peak intensity under 1 minute. But some studies extend this window up to 10 minutes. Unfortunately, in real life, patients and physicians alike are just not very good at figuring out just how sudden somebody's headache was. In fact, one study showed that the inter-rater agreement for a sudden onset was only moderate with a kappa of 0.49, hardly anything to hinge your diagnosis upon. Worse, only 50% of subarachnoid patients actually have a thunderclap headache. And up to 5% of these patients might take up to 1 hour to even reach maximal intensity. What that means is that for any patient with the worst headache of their life, you might have to consider subarachnoid hemorrhage if they reached maximal intensity under 1 hour. Subarachnoids can give you any kind of neurologic findings on exam, all depending on where the cerebral aneurysm ruptured. But if all of these patients actually had a neurologic finding on exam, we'd work up all of them. It'll be easy. The problem is that up to 40% of these patients will have 0 neurologic findings on exam. What that means is we have to rely on their history to better assess and risk stratify for subarachnoid. The Ottawa group found that these 5 features on the slide have a combined sensitivity of 100% for ruling out the presence of subarachnoid hemorrhage. When applied to the appropriate patient, who are patients with acute non-traumatic headaches that reached maximal intensity under 1 hour, you can effectively rule out a subarachnoid. So if you're young, didn't have a thunderclap headache, never passed out, and aren't showing any meningeal signs, you don't have a subarachnoid hemorrhage and you can be spared from radiation. This is able to reduce CT rate by about 15%. If you're a little older, age 40 to 60, where most of the cerebral aneurysms rupture, you will need to do more workup. And we'll talk about that next. Non-contrast CT head is the first imaging modality of choice when it comes to working up subarachnoid hemorrhages. You're looking for the blood in the subarachnoid space, as shown with the star sign on the image to the right. This blood in the CSF becomes harder and harder to tell over time, so it's really important to time the CT head with the onset of symptoms. What the literature says is that if you obtain a non-con head CT within 6 hours of symptom onset, you have a sensitivity and specificity of 99%. With a negative likelihood ratio of 0.01, you might miss one subarachnoid after 1,000 CTs. So you're pretty good. There's some concerns though. Some argue that all the research for this was done at academic centers with expert radiologists and modern CT scanners. For you, that's an uncontrollable factor. But in most EDs these days, you at least have a 16-slice CT scanner, which was considered modern when the research was done. And all the imagings are probably read by at least an attending radiologist. So in those factors, you're probably good. What you really need to worry about is the presence of anemia. There's concerns that if the patient's hemoglobin's under 10 or hematocrit's under 30, radiologists will have a harder time detecting the presence of subtle blood in the CSF, even under the 6-hour time window. So the next time you have a patient with a classic subarachnoid hemorrhage story, a negative non-con head CT, but you find that they're quite anemic, you might have to do more workup. And this brings us to after the 6-hour time window, the effectiveness of non-con head CTs do decrease. At about 24 hours, the sensitivity drops to about 93%. At 1 week, the sensitivity is about 50%. There are some very smart people out there though who've done calculations on this, looking at the prevalence of subarachnoid hemorrhages and the overall low diagnostic yield of lumbar punctures and CTAs in the workup of subarachnoids. They argue, do all of these patients with negative non-con head CTs really need an LP or CTA? How many subarachnoids are you actually going to miss? While their concerns are very valid, it's important for us to remember more research needs to be done on this. And not a single guideline out there recommends or supports the discontinuation of further workup after a negative non-con head CT if the patient has any neurologic findings on exam, any meningeal signs, or you obtain the head CT after the 6-hour mark. And this brings us to the CT angiogram. CTAs look for any signs of vascular abnormality, such as an AVM or cerebral aneurysm, that might cause the subarachnoid hemorrhage. Essentially, if you see any vascular abnormality, you perform the lumbar puncture and try to diagnose a ruptured cerebral aneurysm. Many experts argue that if you use this method, you will be able to spare the patient of a pretty painful procedure that is a lumbar puncture and also save you, the provider, a lot of time. In literature, the sensitivity for CT angiogram for detecting subarachnoid hemorrhage is greater than 97%, with most of the misses being small unruptured aneurysms less than 3 millimeters. Considering the overall prevalence of subarachnoid hemorrhages, the negative predictive value for a negative CTA is better than 99%. And for this reason, ACEP has stated that CT angiograms are acceptable alternatives to lumbar puncture for the workup of a subarachnoid hemorrhage. The problem with CTAs are the incidental findings. What the data shows is that for every one source of the headache that a CTA will find, like a ruptured cerebral aneurysm, they end up finding 3 incidental findings of unknown significance. Mostly small unruptured aneurysms less than 5 millimeters. But you wonder, well, they're small and they're unlikely, they don't look ruptured, and they're unlikely to rupture in the patient's lifetime. That's absolutely true. But the other truth is that small aneurysms are so common that they still make up to 50% of all subarachnoid hemorrhages. And as you recall, most subarachnoids, the bleed initially stops. And what that means is no matter how small of an aneurysm you find, you're still going to have to lumbar puncture these patients to prove that it truly didn't rupture. And think about the downstream consequence of that. Every time you having a severe headache, wondering, is this the time when my small aneurysm finally decides to bleed? Do I have to get a lumbar puncture? Think about the downstream cost of neurosurgical intervention. The mortality and morbidity of surgical clipping for an aneurysm is 1.5 and 6.5% respectively. That's not nothing. I'm no saint about this either. I CTA people all the time. Just the other day, I CT angiogrammed a lady who had scoliosis and I didn't think I'd get a very good LP. She ended up having a 3 millimeter aneurysm. I had to LP her anyways. The LP went a lot easier than I thought it would. And I ended up sending her home. But I also sent her home with the knowledge of this 3 millimeter aneurysm that probably won't rupture in her lifetime, but it could just kill her. That gives me some pause. And that's why ACEP recommends you perform shared decision making with all of these patients before deciding whether to go the CTA route or the lumbar puncture route. I agree with that as well. And now for lumbar puncture. The classic teaching for subarachnoid workup includes evaluation for xanthochromia after a lumbar puncture. But what does xanthochromia mean? How do you even test for it? Xanthochromia is the presence of heme breakdown product in the supernatant of a CSF. What you do to test for it is you get the second tube of the lumbar puncture, you centrifuge it, and you look for the characteristic yellow tint of hemoglobin degradation in the CSF supernatant in the top layer. The really cool thing about xanthochromia is that it actually takes a couple hours before the heme starts to break down. So if you get a traumatic tap, that's okay. Just spin it down, take a look, see what happens. If all the fresh blood goes down and the supernatant becomes clear, you're good. Xanthochromia is negative. But what that also means is if you take a little while before you get the sample tested, you might also end up with a false positive where the hemoglobin starts to break down. Xanthochromia has a sensitivity and specificity of 93% and 95% because of this. So the big question is, there's this lull. Like, if you tap too early, you might end up with a false negative. So how long do you have to actually wait before you can truly rely on xanthochromia? The textbook answer is 12 hours. So what that means is that there's a lull between the 6th hour mark when the non-con head CT starts to become ineffective and the 12th hour mark when the xanthochromia becomes very reliable. There are some other concerns with xanthochromia as well. Many experts believe that the naked eye simply isn't good enough to detect, to truly say there's no xanthochromia. They argue that you need a mass spec machine to detect the subtle pigmental changes of xanthochromia. Unfortunately, most US hospitals don't have a mass spec machine on site, so you're out of luck there. And that's why for most of you, testing for xanthochromia isn't even an option. We're going to have to interpret the lumbar puncture cell count. We all have a bad memory about that time we're evaluating someone for subarachnoid hemorrhage and we got a traumatic tap, we didn't know how to interpret it, we had to get a CT angiogram anyways, and we question, why did I even LP in the first place? Well, what I can tell you is that there's actually a decent amount of evidence for how we can interpret these traumatic taps, and we'll talk about that. The first question is, at what point do you always have to consider subarachnoid and it's not just a traumatic tap? The answer is 10,000. If your fourth tube RBC count is greater than 10,000, that gives you an odds ratio of 6 for the possibility of the patient having a subarachnoid hemorrhage. And this was based on a retrospective study of 4,500 consecutive patients who got an LP for a headache. So if you get a fourth tube RBC count of 10,000, you can't just call this a traumatic tap. You have to consider the possibility of a subarachnoid hemorrhage with a cerebral aneurysm rupture. You need to get a CTA and possibly talk to a neurosurgeon. But 10,000 is really high. You're probably going to be acting on it with 5,000, with 2,500. What we really care about is the low bar. At what point can we say it was a traumatic tap and you're good? If you're willing to rely on xanthochromia, the answer is 2,000. If you have a negative xanthochromia test and the fourth tube RBC count is less than 2,000, a prospective study of 1,700 patients showed that this 2,000 number has a sensitivity of 100%. If you have negative xanthochromia, tube 4 less than 2,000, you're good. But we just said we don't want to rely on xanthochromia. So what's the real low bar? The answer is 100. In that retrospective study of 4,500 patients, it showed that no single patient with a tube 4 RBC count of less than 100 had a subarachnoid hemorrhage. So if you have a tube 4 of less than 100, or just a count less than 100 period, not a traumatic tap. The patient's good. You don't have subarachnoid hemorrhage. But that gives us a huge gap between a count of 100 and a count of 10,000. Unfortunately, that's just how the studies were done. And the in-between number is a little difficult to figure out. So the next step you can do is to figure out the percentage drop of the RBC count from tube 1 to tube 4. And what data shows is that if you demonstrate a greater than 63% drop from tube 1 to tube 4, or tube 4 count divided by tube 1 count being less than 0.37, you have a likelihood ratio for subarachnoid being 0.1. So that can aid you in determining whether something was a traumatic tap or not. And with all of these data, you will be able to utilize this evidence to determine whether somebody had a traumatic tap or if they are concerning for subarachnoid hemorrhage. Let's practice. You obtain the LP 8 hours after onset. The first tube is 27,000. The second tube is 10,000. Is subarachnoid ruled out? Subarachnoid is not ruled out in this case because the fourth tube RBC count is greater than 10,000. These patients should get a CT angiogram, and you should consider talking with a neurosurgeon about further workup. How about this one? 14 hours after onset, you get the LP. Tube 1 is 3,000, tube 4 is 900, and xanthochromia is negative. Subarachnoid is, based on the evidence available, effectively ruled out in this case, and you can call this a traumatic tap. Not only did the tube 1 to tube 4 drop greater than 63%, tube 4 is also less than 2,000 with lack of xanthochromia. So the evidence shows us that this is probably okay. How about this one? LP after 8 hours, tube 1 is 160, tube 4 is 80. Subarachnoid is probably ruled out in this case as well because tube 4 is under 100. Now if you see tube 1 and tube 4, the drop is only about 50%, But that's okay because the numbers are relatively low to begin with, so the yield of the percentage drop is probably not going to be as high on this one. But tube 4 being under 100, it's basically almost as if it wasn't a traumatic tap at all, and there's just really not that much blood. So you're probably okay in this regard. Lastly, LP 8 hours after onset. Tube 1 is 406 and tube 4 is 415. So subarachnoid is unfortunately probably not ruled out in this case, and you should probably get more workup. Now, 400s, anything under 500 is still relatively low in terms of the RBC count, but the concerning feature here is that the number between tube 1 and tube 4 didn't drop. In fact, it went up a little bit, and that's highly concerning. And these patients should get a CT angiogram, and you might have to consider talking to a neurosurgeon. So in summary, when you get a traumatic LP, the reassuring findings are that the lack of xanthochromia, especially after 12 hours, tube 4 RBC being less than 100, and the drop in RBC from tube 1 to tube 4 being greater than 63%. The concerning features that warrant more workup includes presence of xanthochromia and the final tube RBC being greater than 10,000. And with this, let's LP away. In summary, we can use the Ottawa Subarachnoid Hemorrhage rule to try to reduce CT utilization and use some of these clinical historical features to risk stratify for patients with subarachnoid hemorrhages. CT angiogram is a reasonable alternative to performing a lumbar puncture, but given all the incidental findings and downstream cost, we should perform shared decision making with all of these patients before deciding whether CTA is truly better than performing a lumbar puncture. And lastly, traumatic taps are interpretable. There are evidence out there that can help us. So the fear of getting a traumatic tap should not be a hindrance to us pursuing the LP route. Thank you everyone for attending my lecture today. Have a good day.
Thank you very much. That was a great review of just a ton of evidence for something that kind of gives us a lot of headache and frustration ourselves. Can I ask you a couple of questions?
Yeah.
So the first one is about the ACEP recommendation. It makes it sound as though you can just offer LP versus CTA. My concern though is that I think most patients, when you tell them about the needle versus getting one more CAT scan if they already had one, that I'm just worried a lot of people are going to really opt for it. So are you doing true equal shared decision making, or do you still have a tier to it about what you recommend more strongly?
I try really hard to tell patients exactly what I think. And the big thing that I tried to bring up is the fact of all these incidental findings and having things to just really think about and keep you up at night, especially with these incidental aneurysms and AVMs you might find that honestly will probably never bother you for the rest of your life, but you'll have to know about for the rest of your life. And some patients are okay with that, some patients aren't okay with that, and I've been able to talk people into LPs. And truthfully, most of the time, patients just tell you, do whatever you think is the best. And I try to push for the LP, especially if I think I can get it relatively easily.
My other question would be, it seems like with all the difficulties around CT interpretation, how long it has to be before you can rely on it, and then this window, and whether you can test for xanthochromia or not, I took from this, I'd really like to not have to go do the workup at all, so the Ottawa Subarachnoid Rule looks really attractive. Has that been externally validated anywhere, or is it still sort of only validated in the people of Ottawa?
I don't remember. I don't remember the answer to that. I apologize.
I haven't seen anything yet either, but I don't know if there was something underway.
The other big thing is I think the Ottawa Subarachnoid Rule works better as a guide when it comes to thinking about working up subarachnoids, it really only decreased your CT utilization by about 15%. And the biggest thing is to essentially reduce workup for patients who are under 40 who really probably don't have subarachnoid bleeds.
Well, thank you very much. That was a great talk, and I really appreciate you giving it.
Thank you so much.